Welcome to the Brain People Podcast, a show where four mental health experts team up to bring you practical tools for overcoming mental health challenges. The Brain People don't replace your doctor or therapist, but we will give you some extra tools to help you on your journey. So join us as we fight mental illness, one episode at a time. Welcome to the Brain People Podcast. I'm your host, Dr. Daniel Binus, and today I am joined by my co-host,
Amanda Anguish.
And today we're going to be talking about a very interesting topic that is pertinent to a lot of our patients, and also we've all maybe even had personal experiences in our families or acquaintances with individuals that struggle with OCD, in other words, Obsessive-Compulsive Disorder. So this is something that I think a lot of people can definitely resonate, and certainly it's one of those things that a lot of people talk about in pop culture too, just as far as like, oh, don't be so OCD. Or don't be
I'm so OCD.
obsessive or whatever. So we want to get a little into what OCD actually is, and then also talking about where it comes from, how it's working in the brain, and then also some treatments for OCD. So let's go ahead and dive right into it. So Amanda, could you talk a little bit about what OCD actually is?
I could talk a lot about what OCD is, but I'll talk a little bit about it. So OCD is a mental disorder that a lot of people struggle with, that probably realize they struggle with it, but it also often causes shame too, because it's sort of this internal conflict that a person has where they have pervasive thoughts, ideas, impulses, and images that just keep coming back and keep coming back. It's like having your playlist play over and over and over again, but it's not a wanted playlist. It's not something you put in there. It's something that you're just inundated with. And that's where we get this that's where we get OCD from, because it's an anxiety disorder. So when we talk about things like depression and anxiety, we're not just talking about one disorder, anxiety. We're talking about an umbrella term, and OCD is one of those anxiety disorders. So that's where the anxiety comes in, because it's unwanted, persistent, pervasive images and thoughts and ideas and impulses that a person is inundated with that they can't seem to shake.
And it really seems like it starts to control their lives in a lot of ways.
Absolutely. And that's one of the factors that OCD has to be, is it has to control your life. I think it's at least an hour a day that you have to be overwhelmed by these things. And it literally stops you from being able to progress normally through your day. And so when we have those unwanted thoughts, images, impulses, whatever, that's what we call the obsession part of OCD. And then because of that obsession part, then comes the compulsion part. So while that anxiety is increasing and building up, well, we want it to release. I don't want to keep experiencing that, and just like a volcano has to erupt, that's where the compulsions come in. So in order to release that anxiety, I believe, and that's the operative word, I believe that I have to do a compulsion to do that. So a compulsion is any behavior, and behaviors can be physical behaviors, but they can also be mental behaviors. So sometimes those behaviors can be like thinking about something multiple times in order to release the anxiety of a thought or something like that. And so that's where we get the term obsessive compulsive, because it's always about the anxiety, the obsession is building, and then the compulsion is to release. It's like to let the air out of the tire so that it can calm down. But the problem is as soon as you do that compulsion, all you're doing is reinforcing the obsession.
Yeah, because you're saying, okay, well, by doing that compulsion, you feel better. And so therefore, you just need to keep doing these compulsions whenever you have discomfort, this anxiety building up from the obsessions, right?
Yeah.
So what are some subtypes when we talk about OCD? There's different types of OCD that we think about. And what are some maybe subtypes of OCD, so we can start talking about some examples of what this might actually look like?
Yeah, so we all typically, when we think of OCD, you think of that person that I've seen memes about this where, oh, somebody painted the sidewalk uneven and oh, it's driving me crazy. So that is where we have like the ordering obsession. So that would be where I need to have things in order. Those kinds of obsessions. But then there's also like the checking obsessions where I have to keep going back to the stove, or I have to keep going back to my car to make sure that it's locked or the stove turned off or the door, shut or something like that.
That's almost seems like more of almost the classic
Yeah,
OCD,
those are the
right?
ones that we typically think of. And then sometimes we think of the ones that fall under contamination too, where we're obsessed with bacteria, germs, viruses. Even some people during COVID, they were almost reinforced with their contamination obsessions, because what were we telling everybody to do? Wash your hands over and over again.
That's right.
Avoid touching things. So I don't want to say everybody became OCD, but it reinforced in those people who already had a contamination. But then we also have hoarding and saving and collecting obsessions too. And, there's even a show on television, I believe it's still on, called Hoarders and stuff, where you are obsessed with, you're holding on to something. Like, I have to hold on to this and I have to accumulate more of this too. So we have a hard time letting go. Then we also have things like religious or scrupulosity. Now, we have to add some detail to that. So when we're talking about religious, these are things that don't come from a bigger culture idea. So for instance, Catholics, they do the Hail Mary and that sort of thing, or pray the rosary multiple times. But that's part of a culture, so that's not considered religious. It has to be outside of that culture. So I have to pray. I had a client who had to pray for so many minutes and so many seconds every time they prayed, and then they were even motivated more to pray by, oh, I missed the exact amount of time. And so that's a type of scrupulosity, but it has to be outside of a cultural norm, just like contamination can't be, I have to open the door of the bathroom with a paper towel because now everybody's doing that, or I have to use antibacterial.
It goes way above and beyond.
Yes, it has to go above and beyond cultural norms and stuff. So then we also have somatic obsessions too, where people are obsessed with parts of their body that they may be looking at as though it's not normal. It can also be, oh, this dry throat that I have, it's a sign of cancer or something, or, oh, I can't stop thinking about my dry throat. And so it becomes an obsession. I keep thinking, and then maybe I have to keep drinking water in order to keep that from happening. Then we also have, and this one's a not so obvious one, we don't hear about this one too much, aggressive compulsion. So there are people who are genuinely angry in this world and want to hurt people. They want to fight people. But then there are also people who obsess about hurting people, hurting themselves. Have I hurt somebody? And they don't want to hurt, but their brain keeps telling them over and over again, you might have hurt that person. Did you hurt that person? Did what you say? And so we obsess about, was I too aggressive? Or we have an anxiety about, will I hurt this person? Should I punch this person? But we have no desire to necessarily. And sometimes even people will obsess about suicide. And the average person, that non-expert, would think, oh my goodness, my child is suicidal, but they're not actually suicidal. They're worried that they might hurt themselves in a suicidal way. And so that's what we call like the aggressive.
And so the aggressive, in a way, can actually be aggressive thoughts towards others, but even towards ourselves, potentially too.
Absolutely. We can have aggressive thoughts towards ourselves in terms of like, should I cut? Do I want to cut? Will I feel better if I cut? But no, I don't really want to do that. And there's always I should say, the people I've worked with, when they have that aggression, there's always the fear of, what if I hurt myself, within the obsession of, I feel like I need to hurt myself, or I feel like I'm going to hurt somebody, but they don't actually want
The
to.
desire is absent. So it's not like
Yes.
I'm really wanting to hurt myself or somebody else, but it's just that thought that keeps repeating,
Yes,
repeating,
it's that
repeating.
broken record that keeps saying, did you hurt that person? Did you run over a dog or something? And so they'll literally go back and check multiple times. They didn't run over anything, but the fear of, did I run over somebody? The anxiety of, have I run over an animal, keeps coming back and keeps going over
Yeah, I
and
had a
over.
patient who really struggled with that. I mean, it would take him literally sometimes hours to get home after work because he constantly felt as he was driving home from work that, ooh, I think I might have hit somebody. And so then he was looking in his rearview mirror, but then his eyes were not on the road. And then he was like, oh, maybe when I was looking at the rearview mirror, I might have hit somebody or something. And so he would have to turn around and it would just go back and forth, back and forth. And so then you see that obsessive thinking going on. And then, of course, the compulsion being the checking.
Absolutely. And then similar to the aggression one too is the sexual obsessions. Similar that it can be an aggressive sexual thing, but it can also be just obsessing about sex, but not necessarily, like you said, taking pleasure in the thought of it, but just obsessing as though it's a thought that you can't let go of, and it just keeps building and building and growing and growing. So that's the last of the major categories. Actually, no, there are two other ones. There's a let me remind myself. There's body image. So sometimes we can have body image. So we're looking at a certain part of ourselves and so obsessed on focusing on that body part that we miss everything else. And then another one is health obsessions. Like, is this, and this can kind of go with the somatic one too, but do I have a disease and stuff? And it's not the same as being a hypochondriac. It's just you're so focused on, maybe somebody in your life had cancer, and so you can't stop thinking about cancer now yourself, and you just obsess about it. And then, of course, there's a bunch of other myriad of miscellaneous ones that we don't have to go through just for the sake of time, but those are all the obsessions that we know of, categories at least.
So that really helps us to understand that it is a very broad sort of thing. I mean, we can obsess about a lot of different things in a lot of ways, but again, I think the common aspect that we're looking at is that there's that cognitive component, which is the thoughts and the feelings that are coming up related to the thoughts, and then there's in some way, there's a compulsive component. Now, the compulsive component can even be cognitively too, right?
And so a lot of times we think that the compulsion, so the compulsion is always, what do I do to get rid of or release that anxiety that's been building up? But sometimes a lot of people just think when they have OCD, it's not because they choose this, but obsessing more actually makes them feel like they're doing something about it too. So it can be a behavioral thing like washing your hands to rid of the germs, but it can also be, if I keep thinking about this, somehow it's going to have some magical effect on this too.
Yeah. And then, of course, there's like counting and all sorts of different things that people might do more mentally to try to alleviate that anxiety. Or even, like you mentioned before, I have met, some Catholics, for example, that it's like, okay, there's that norm of having certain amount of Hail Marys or whatever. But then people with OCD that are Catholics, they might go like 1,000 times more on that, right?
Yes. And so it's almost like, and this is, sometimes I wonder how much this plays into it, like an eating disorder. You have to eat, but at what point does it become an out of control issue? And that's the same with OCD. Who doesn't count? But then when does it become a compulsion? Or we wash our hands, but when does it become a compulsion to wash our hands?
Absolutely. So I wanted to touch just a little bit on the neuropathology of OCD and basically thinking about what is going on in the brain. And the reality is, science is not 100% sure exactly how OCD works, but what we do know is that there are changes in the frontal lobe and also in the basal ganglia. And so it seems like both of those parts of the brain are very much involved. And essentially what we know is that there's the orbital frontal cortex and also the anterior cingulate cortex. Those are both parts of the frontal lobe. And the orbital frontal cortex is involved in reward and punishment. And then the anterior cingulate cortex is involved on some levels with error monitoring. And so a lot of researchers have hypothesized that the anterior cingulate cortex is basically not giving a proper signal when it comes to like, oh, you've completed this task, for example, successfully, like good enough, right?
Yeah.
It's saying, no, you haven't quite done it enough and you need to try more. And then the orbital frontal cortex, because it's involved with the reward and the punishment, is basically saying, yeah, you're going to get punished if you don't fulfill this task properly, or you're not going to get the reward, right? And the orbital frontal cortex studies show that in most people with OCD is smaller, it's atrophied, and so it doesn't update the reward process properly. And so essentially someone is like doing a task or maybe having a thought, and then there's part of your brain that's like, no, it's not good enough and you need to do it again. And then the basal ganglia is involved in actually motivating us to follow through with things. So the basal ganglia has to do with like automatic kind of movements and processes, and it's also involved in reward as well. And so you can kind of see how this system, if it's working properly, then your brain will be able to assess and say, okay, well, maybe I didn't do it quite perfectly, but it's good enough. Let's move on. Or yes, I did check that the stove is off, and kind of updating that and letting that settle in. But if that part of the brain that essentially tells you the task is complete is not working properly, then the signal doesn't go back to the basal ganglia saying, hey, it's okay, we don't need to do this again. And then the basal ganglia is like, okay, no, we need to keep doing. And so it's this system that basically just keeps going, and there's no stop switch.
Yeah, and almost the opposite. You get a reward for keep doing it versus not. You get the reward, and I don't know if that's dopamine or whatever. You can probably explain more on that, but it's almost like I get addicted to continuing the process over and over again, and even to the point where anybody around you, anything that's going on around you, gets completely ignored.
Exactly. And I think a big part of that reward is essentially the alleviation of the anxiety that is building because, hey, I haven't quite completed this the way I should have, is what our brain is telling us. And so that gives us anxiety because I need to do more. I need to do more. It's not good enough. It's not good enough. And so then when we do more, then it's like, oh, okay, the brain is rewarded. You get those extra neurotransmitters released that make you feel a little better temporarily, right? But then, like you said, it just ends up being this vicious cycle because you're feeding it.
Yeah, and one other thing too that, I'd like to add is that people who have one obsession, maybe that's their predominant, it doesn't mean they won't have other ones too. So we can have clusters of them. You can have one, or you could have three, but maybe one is more the dominant one. And then over the course of your experience with OCD, you can actually have it manifest in other ways too throughout. So I've seen people, and I've worked with people who it'll start out with one thing being the predominant, maybe germs or something like that, but then it'll kind of morph into another type of OCD as well.
So before we dive into treatments for OCD, one thing I wanted to kind of differentiate is the difference between OCD and what we call OCPD, Obsessive-Compulsive Personality Disorder. Can you enlighten us a little bit about what we might say the main difference is there?
Yeah, so OCD is obviously the obsessions with the compulsions, but when it comes to OCPD, this is where the person in your life, or even you yourself, you're dealing with a very rigid personality in the process of it. And sometimes it's hard to know the difference. So this doesn't mean that you have to decide or diagnose the person, but that person will have like certain rituals that they have to go through that seem to be a little bit more than just the OCD, and it becomes a part of their personality. Like, I have to do it this way. And it's not just in the moments where OCD is happening, it's pervasive throughout their personality. So it's like another way of saying it's their style. It's their pervasive style of the personality, and it shows up in a different part of our diagnoses too. It's in the axis 2 where the personality disorders are versus an axis 1 diagnosis and stuff. So it's very much about the personality.
So it almost seems like it's a hyper perfectionism, so to speak, rather than as much about the obsessive type thinking and then the compulsions to relieve that. It's more of like, okay, I'm just have to do everything, or at least this part of what I do perfectly. And some of these individuals that I've seen, it can take them so long to do any task because they just have to do it exactly perfectly. And if not, then I have to do it all over again. And so it is different. And it does seem like it tends to be pervasive in almost everything that they do in life.
Yeah, OCD tends to be more focused in certain categories, where OCPD is across the board. This is I hate to say this is who I am, but the rigidity is just such a pervasive pattern throughout everything versus the OCD. And I'll say, I'm just thinking too, as I work with people with OCD, when they're in a vulnerable moment, will often lament what they're going through, versus the OCPD person doesn't recognize why other people don't understand why I have to do this. Like, what's wrong with you? I have to do this way. Why aren't you okay with that? Versus the OCD person might be frustrated at first, but then they're also frustrated that they're overwhelmed by this thing that's happening to them versus this is who I am.
That makes a lot of sense. So let's go ahead and shift into treatments a little bit for OCD. And since I'm a psychiatrist, maybe I'll touch first.
I'll let you talk about the medication stuff.
And I'll touch on that really briefly because I really want to spend the majority of our time talking about the therapies for OCD. Because what we actually find is that medications are effective in roughly 40 to 60% of individuals. And so there's, it can be helpful for a lot of people, but there's really a lot of people that continue to struggle. And even if the medications are partially effective, I've had a lot of people that are like, yeah, it's a little better, but I still am struggling. And what we find is that therapy, on the other hand, especially specific types that we're going to talk about, are helpful for 65 to 80% of people. And some studies show that when you combine, medications with therapy, there are better outcomes. But overall, therapy is actually more effective in the long run, especially when we talk about OCD.
And when you're not resistant to therapy too.
Yes.
So it's 100% effective if you're not resistant to the therapy, which oftentimes OCD is very resistant to doing therapy.
That's true. And that's an interesting thing to bring up because there's an element of a lot of people with OCD will initially pursue therapy, but then when they see the work that's involved and the discomfort that comes up facing the obsessions and the compulsions and trying to change those, it can be very overwhelming and makes
it's hard work.
Yeah, it is.
It's worth it though.
It is. Yes, it is. So as far as typical medications, the first line treatment for OCD is selective serotonin reuptake inhibitors. So things like Zoloft, Prozac, Paxil, fluvoxamine, that sort of thing. And again, they can be effective for a fair amount of people. But
are those supposed to like relax you and to take off the edge? Like, how do those work?
In essence, they basically, a lot of researchers believe that they do work at the level of the anterior cingulate cortex to basically, which remember, that is part of the brain that's often involved in OCD. And it seems like it reduces the amount of anxiety that's related to the obsessions. And so people could still potentially have some of the obsessions, but then they're able to more easily dismiss it because it's not becoming as, the anxiety level is not becoming as pervasive because I'm not doing this, and this, the compulsion, right? And so it does reduce that overall anxiety for a lot of people. And then over time, the obsessions and the compulsions start to diminish as well. And then the second line treatment, if those fail, there's an older antidepressant called clomipramine that is often very effective for OCD, but it also has a fair amount of side effects, and that's why it's not the first line. For a lot of people, it's actually more effective than the SSRIs, but because of the side effects,
Yeah.
it's
What are
not.
some of the side effects?
Well, it can be like dry mouth, urinary retention. So it typically related to what we call anticholinergic side effects, and then also sedation. So those are some of the common ones that can be associated. And then
It's
there's
not fun to be sedated all
no,
the time.
no, exactly. And that's why a lot of people aren't too excited about trying that one, at least first line. And then there are a couple supplements that have been effective for a fair amount of people, and I've seen some success with these as well. And that is N-acetylcysteine and then inositol. And so they definitely don't work for everybody, just like the meds don't work for everybody.
Yeah.
But those ones typically are very well tolerated and lower likelihood of side effects. So oftentimes I encourage people to at least try those first, along with psychotherapy. And then
Yeah.
if people are feeling stuck, then we can try medication. But a lot of people, by the time they come to me, they've tried some of these, or they were just feeling so discouraged that they're like, "Doc, just give me meds." And I'm like,
Yeah.
okay, we can, I get it. At that point, we'll often try medications. But again, I think it's so important to also do the psychotherapy, regardless of whether you're doing medications or not. So, but let's go ahead and shift into talking about therapies that are helpful for OCD.
Yeah. So the main, like all encompassing therapy that seems to work the best is not just talk therapy, but cognitive behavioral therapy. So, cognitive behavioral therapy, we've talked about this before, but it has to do first with our cognitions and how the changing the way we think or our cognitions, we ultimately affect how we behave, which affects how we feel too. And so, one of the types of therapies within cognitive behavioral therapy is exposure therapy. So that's a form of behavior, and it also has to do with our thinking, because what happens when I keep exposing myself to the very thing that I'm fearful of that's causing the anxiety, and then I realize, oh, that's not affecting me the way that I thought it would. So if I didn't do this or I did do this, oh, those germs aren't killing me. I haven't died from germs and I've been exposed to them and I didn't wash my hands multiple times. Well, oh, so because I'm doing it over and over again, I'm exposing myself to that very thing, I become less afraid of it. And it's actually, in fact, worse to continue to do the compulsion because all it does is reinforce. So if I wash my hands, then what is actually happening? I'm reinforcing the belief, which is the cognitive part, that, oh, this washing is helping me avoid germs because I'm not getting sick. Well, what if I wouldn't have gotten sick anyway? So if I don't wash my hands when I feel compelled to or have an obsession to, then I find out, oh, I didn't get sick. So that's what we mean by exposure therapy. So we start to expose ourselves to the things. I don't go back when I'm worried that I hit somebody with my car. I don't go back and check the stove. That's exposing myself to the anxiety to recognize that, oh, maybe that doesn't in fact hurt me the way I think it's going to.
One of the questions that I would have along those lines is, a lot of people with OCD are like, yeah, I know I need to just stop and not keep washing my hands or not wash my hands at all. And so if my therapist tells me that, it's like, okay, I already know that. So how is CBT really going to help me, or how is it even really telling me anything I don't know?
Yeah. So one of the things that we have to do with that is, when we're going through that exposure, sometimes the exposure is just even putting it off. Like I recognize, oh, say I need to wash, or I think I need to wash my hands. Well, if I wait 20 minutes before I do it, what's the difference waiting 20 minutes than just doing it then? Oh, well, maybe I can put it off 30 minutes next time. And then we keep doing that, and it changes our thoughts and our beliefs about the actual fear or what might happen if I don't do that sort of thing.
So, what do cognitive behavioral therapists then do to kind of move people along that continuum?
Okay, so one of the things that there's a book called Brain Lock, and Jeffrey Schwartz is Jeffrey Schwartz is the author of that. He talks about the 4 R's of overcoming OCD. And by the way, if you're listening to this and you're dealing with anxiety, I think it's actually quite helpful for anxiety. And even I've thought about it more, and I'm like, well, this works for even depression too.
Okay.
So it's for OCD, but it can actually work for all kinds of things. But the first R he talks about is relabel. So when I have a thought that tells me, and I'm just going to use the washing or contamination one as an example. When I have a thought that tells me you're contaminated, you need to wash your hands. Well, what do I think about that thought? Most of us don't realize that we just accept the thought and we carry on as though it's true. But to acknowledge, this is just a thought. I have many thoughts that go through my mind. I have many thoughts that go through my mind during the day or the week or the month or the year. Why is this one so valuable? So just acknowledging it's just a thought. And every single person, we do this all the time. We have thoughts that we don't act on.
It reminds me of that saying, don't believe everything you think.
Yeah,
right?
Don't believe everything you think. We can have thoughts like, I should get back together with my boyfriend after a breakup. But then we
Right.
think about that thought and we go, why would I do that? There's a reason we broke up. You're thinking about what you're thinking about. And that's important, that metacognition, thinking about what you're thinking about. Because even just being mindful of, I'm having this thought is happening, but I don't have to value the thought over any other thought that I could have.
So that's the relabel.
That's
part.
the relabel. So you're merely, whatever that belief is, I need to wash my hands, for example. Oh, that's just a thought.
Yeah, and you can say, well, it may be true, it may not.
It may be true. I haven't calculated the value of this yet. It's just a thought at this moment.
So what's the next R?
So the next R is reattribute. If I already know that I struggle with anxiety and I know specifically OCD, well, where is that thought coming from? It's coming from the OCD. And so oftentimes what we do is we start to identify with our OCD. We go, oh, my OCD, this is mine, this is me, this is me. And so instead of saying, this is me, I have to do it, recognizing, oh, this is just the OCD talking. It's not me, it's the
my
OCD.
Okay, got it, yes.
Not everybody has OCD their whole lives. So who are you then when you don't have the OCDs? Or who was I before this OCD became an issue? Well, then it's not me. I don't identify with OCD. OCD is just something out there. I like to think of it as a really convincing, emphatic friend trying to make you believe something. And the more they talk, it's easy to start to believe them if they become more and more emphatic about what they're saying, if they are very forceful about it. And, if you hang out with somebody that long, you're going to start to think you believe them. But that's just the OCD talking. Just like, oh, that's my crazy friend over there trying to tell me that this is how it is. I know it's not true. That's just the OCD. It's not me. So so that's the first part of the 4, and that has to do with the actual thoughts. But what happens if you stay too long with a thought? Even when you rebuke it or suggest that it's not true, it's still going to have an effect on you. So the third R is now I need to refocus. And he talks about doing holistic, like healthy things with your time instead. So this is where that 20-minute thing would come in. So I feel like I need to wash my hands. I believe that my hands are contaminated and I need to wash them. Well, I've already relabeled it. So now I'm going to focus on something that's even better. Like something pure, something better than washing my hand right now. I'm going to go do something nice for somebody. I'm going to go write a card for somebody who's been kind to me or something like that.
So basically a positive distraction to get your brain completely on something else. And
to refocus on something else.
You know what? I'm not talking to you anymore, OCD. Mm-hmm. I'm going to go do something else because you just are bothering me right now.
I like to think of it as like a door-to-door salesman, what do most of us do when
I'm
somebody
sorry,
comes
I'm
to
busy.
the door? That's even if you go to the door. I have many times, especially when I was single and lived alone, I would pretend like I wasn't even there. And I would go do something else. I'm not going to sit there and hang out by the door in case that they know that I'm there. I'm going to go do something else and pretend like I didn't even hear the doorbell ring and stuff. So distracting yourself with something better. It could be working on a garden. It could be doing all kinds of things, refocusing on your child. My child needs my attention too.
Right.
I'm not going to go wash my hands right now. Now's not the time.
Yeah, that's actually a good point. A lot of people, when they have kids, it helps their OCD. I've had patients who have had a child, and because it's such a distraction,
Yeah.
and they love their child so much, it's like, you know what, OCD, you're not so important anymore.
Yeah. And I love that too, because I've worked with people as well who've had that same inclination to where, oh, I don't want to, I don't want to focus on this because I have my child or my child's distracting enough. And they actually also think, I don't want to teach my child that this is normal.
Yeah, that's
that
true.
this is normal, because I know in the deepest parts of me, even if I'm confused sometimes, that this is not normal. And I don't want my child to go through this too. So refocus on something better. And if you have somebody to do that for, great. And then the last thing is revalue. And I like to think of this in terms of, like a drone. If that drone is on the ground, what's its perspective? Just whatever's around it right down there. But if you lift the drone up higher and higher and higher, you see the world so differently. And when we're focused on, say, washing my hands, well, what am I missing out on by refocusing on this over and over again? I'm going to revalue my life. I'm going to look at it from a bigger picture. Because this is the problem with OCD. We become hyper-focused on something. And like you said earlier, that person that you worked with that couldn't keep their eyes on the road. This is one of the problems with OCD is you become so hyper-focused on one thing that people will get themselves in accidents over focusing so much on this thing over here versus, hey, I'm supposed to be a defensive driver looking out all my windows,
Right.
recognizing all kinds of things. And we become so minutia focused that we don't see the bigger picture, the bigger value. And if we just step back and go, in the scheme of things, how important is this that I wash my hands right now? Like, how important
big
to
picture,
this,
right?
to the world and what's going, there's wars happening over here. There's, the government might be shutting down or something. Like, in the scheme of things, is washing my hands really that important? But another aspect too is that the bigger picture is also, if I'm focusing so much on germs that I'm washing my hands over and over and over again, what is actually happening to my hands?
They're getting more prone to infection. And
what is skin for?
Right.
Skin is to protect me from germs. But if I'm washing my hands 200 times a day, and that's not a small number for some of the people I've worked with, my hands are literally peeling their skin. What have I just done? The bigger picture is I haven't protected my hands at all.
Done the opposite.
I've done the exact opposite. I've made myself more susceptible to germs.
And another piece of that might even be the bigger picture of the time that I'm taking away from my family or from my spouse or friends or other things that I value in life too, right?
I heard a story about, I don't remember who told the story. It might have been the guy who had OCD, but he had a terrible, terrible dealing with germ OCD. And it got so bad that he was basically debilitated in his apartment. I think he lived in New York at the time. And his family, they didn't know what to do. Like, everything they tried didn't help him. So you know what his brother did?
What?
His brother took him on a walk. He said, "You're going to come on a walk with me." Didn't give him any choice. So he's on this walk with him. They're walking down the street, and they'd walked over all kinds of, like, New York City's not the cleanest place when you've got millions of people walking and walking and walking. His brother stopped, picked up his shoe, and licked the bottom of his shoe.
Oh, wow.
And he realized the bigger picture of his OCD. Like he was so worried about germs. And here his brother was willing to lick his own shoe to prove the point that you're not going to die from germs. And I don't know how much it cured him, but he said it just
It helped.
changed his perspective on what he was doing in his life. And I think that's the fifth R, if there was a fifth R. It's reframing. Being willing to look at things differently. We get so often narrowly focused, and I think this is for all of us, not just those who deal with OCD, is we get so narrowly focused on something that we miss all the other stuff that's going on. And if we're willing to reframe, like, what's the value of this belief? What's the value of this thought? Do I really, what happens? What are the pros and cons of believing this the rest of my life? What is my life going to look like? It gives us a much better perspective of what we're going through.
Well, that's very helpful. Thank you. And I have one last question that I wanted to ask you. From your perspective, working with people with OCD, the spiritual aspect, like you said, there can be that scrupulosity, but also there can be, I believe, a healthy way to engage with God and really allow Him to help us as we're dealing with OCD symptoms. Any thoughts that you have?
Absolutely, because just like, if somebody has an eating disorder, you don't tell them to stop eating.
Yeah.
And that's the same even with scrupulosity. Is one of the things that I think is very helpful is reframing the character of God. And not because he's changed any, but because sometimes our view of him creates this idea, and it can even go to perfectionism about things. But if you truly understand how much God loves you, doesn't want you to suffer, you can actually speak truth to those things that you're hearing. Jesus spoke truth when he heard lies. And so often when we're dealing with mental illness, we're dealing with lies that we're believing. And this is something as well that I think that families can really benefit from hearing. When you have somebody in your life that's struggling with OCD, oftentimes they will come to you for reassurance, like, did I wash my hands? Or did I wash my hands enough? Or something like that. Or I need you to wash your hands to make me feel better. I think it's very important that we speak the truth in love, and that's what the Bible tells us to do, is that, no, this is an irrational belief. I'm not going to wash my hands right now, because so often if we say that to the person, that is not going to be acceptable. Mm-hmm. We're going to get a backlash of all kinds of frustration and everything, because what is ordering that person? It's the OCD. They're under the spell of that lie that I need to do this. And we don't want to come under that spell. So it's okay to speak the truth to somebody in love with a very loving attitude and say, I'm not going to wash my hands right now, because that is not the answer to this problem. It's what you want to believe is the answer, but all it does is perpetuate the problem. And so, no, I am not going to wash my hands.
Absolutely. And even as I'm thinking about that, and I'm thinking about how that truth really does, like Jesus says, sets us free, as we go through these elements of relabeling and saying, that's just a thought, and refocusing and reattributing and revaluing, that we can really engage with God and say, okay, God, help me, give me the power, because I don't have that brain power to really maybe even feel it or believe it right now. But there's an intellectual part of me that knows this is true, that it's just a thought, and knows that I should be focusing maybe on something else right now, knows that I can attribute this to, this is not me, this is my OCD, and also seeing that bigger picture. And I think that if we give permission to God, through this process, along with, of course, mental health professionals that are caring and supportive, and even family that are potentially caring and supportive too, we give that space, we give permission. I think there's a power that God can bring in that nothing else can really supplant, and give us strength to, get through it. And it doesn't mean that, if I'm struggling, that haven't prayed enough, or I'm not spiritual enough. But I believe that God has so much compassion, when we're struggling, and really wants to come in that moment with us to help support us.
And I think that's the key, is He's with us, because that's one of my favorite passages in Genesis, when Joseph is in prison and it says God was with Joseph. Mm-hmm. And God never wants us to have to go through these things, but He can use them to honor and glorify Himself and also reap benefits back to us as well. And I as you were talking earlier, it reminded me of a very popular verse, Proverbs 3, 5, and 6. It says, "Trust in the Lord with all your heart and lean not unto thine own understanding." And so often we focus on, well, this is what I think. But He'll direct our paths if we focus on what He says versus what we feel or we think. And our culture is very much emphatic about trusting in how you feel, but look where it's gotten us. We just have more depression, more anxiety. I think we need to trust more in what God says.
And His paths, and even how He can help direct our neural pathways as well.
Yes,
right?
He can direct our neural pathways. That's a nice way of thinking about it. I think there's a talk in there somewhere.
Well, thank you so much, Amanda. I really appreciate all your key insights. And thank you to our listeners to tuning in. And hopefully this was helpful for you. If you're struggling with OCD, or if you know someone that is, remember there are treatments that work, that it can be helpful, and there is hope. And with God's help and with the assistance and support of people that are professionals and also that care about you, you can make progress.
Thanks for listening. To hear more episodes, find us on social media, or support us financially, visit thebrainpeoplepodcast.com.